when you're doing this kind of work, have you come up against sort of barriers that are outside of the organizational domain? So policy barriers or funding barriers or regulatory barriers that sort of jived up against the kind of work that you were doing? And secondly, how do you scale this at a system level? So we're working inside provider organizations. In our case, we're working at kind of points of transition between provider organizations. How do you, or have you thought about how we might scale it at a say, a regional, provincial, or national level? So either one or both, we would love to hear.
Thank you, Kathy. I'll start with the scaling up question. The question is, what are you trying to scale up? In this case, what you're trying to spread is a method of working rather than the actual changes that you've made. So, you know, Helen showed the differences that one group of patients issues and another. So you're not trying to scale those. Okay. Now, what we've seen is that it spreads, the method seems to have spread horizontally. That's to say, in South London, where we did it initially in breast and lung cancer, in Guy's and St Thomas's and King's College London, what we found was that clinicians working in other parts of the cancer services in those two hospitals learned about the methodology and have chosen to apply it in their own service. We've also seen it literally cross the road into the mental health services. And there, what you need to do really is to think about how you're going to train trainers and facilitators, I would say. But one question that has certainly been directed at me when I've been speaking to an audience who all work in, for example, accident and emergency services is, are you really saying that we've got to apply this in every department in our hospital? And my answer to that is possibly yes, but actually you don't need to do probably necessarily the full Monty as Helen has described it. That you can. Did I really? You can. The important thing is to stick to getting patients into the room with the people who work with them. I think that's where the real dynamism of this lies. And most of the EBD process is about the preparation for getting into that room. Now, you can get there faster and simpler, and you can certainly do it faster after you've done it the first time in a service, because people get it.
Helen?
Yeah. Just to add to that bit about doing the full Monty, one of the things that we would also say is that sometimes if something has been identified within a particular service that might need to happen. So, for example, one of them was just about where the weighing scales were. So the weighing scales, when people were coming into their in for their outpatient appointment, they were being weighed in front of everybody else. Not that anybody could see the actual, what the numbers were on the scale, but still, you know, anybody who's been to a slimming club will know how that feels, standing on scales in front of people, even though they can't see you. But actually, you know, what happened was that as those scales were moved, they were actually then moved in all clinics. As soon as the message went out, it's like, oh my goodness, that's the same in our clinic, we need to move them. So actually some of those things do just happen. And the other thing is as well is sometimes if it's something that might be a bit more processy or information, sometimes just test it. Testing might be your way of understanding whether it's working in another system. So you might want to move it from one place to another, spread. So you might want to test something. So use the test and learn part, the prototyping element, sometimes as well as part of your information gathering if you've already done some of that work.
Just on the barriers thing, I think the biggest barrier that we encountered was to do with governance systems in the NHS, which are extremely cumbersome and also unclear at the moment. So you'd get trapped in a certain kind of governance, which was about research governance, and a different kind of governance that was about clinical governance. And that can slow it down. It doesn't actually stop it. But apart from that, I wouldn't say that we have really encountered barriers of the kind that you're talking about in the wider system.
Good, thank you. Matt?
Great. Hi, my name's Matthew Morgan from Mount Sinai Hospital in the Department of Medicine at University of Toronto. Thank you so much for a wonderful presentation. It was really great to see such best practices being implemented and making a difference. Question about physician engagement. Obviously, it's tough in any type of change management opportunity, but clearly a huge opportunity to work with a key stakeholder group that may have a great deal to benefit personally and as part of the team. Any suggestions on how to engage physicians in this?
Patient stories. Patient stories do it every time.
We were fortunate. The work in South London was actually kicked off by the head of breast surgery, who's passionately interested in patient-centred care. And so he did a lot of work with his colleagues. I think patient stories are really powerful, but I think doctors are very influenced by each other, and therefore getting one or two key clinical champions is probably very important.
Over here, Carol.
Hi there, Carol Fancott from University of Toronto and Toronto Rehab Institute. I'm wondering, thank you for a great talk. I'm wondering if you could speak a bit to the evaluation component, both process and outcome evaluation of what you're looking at along the way and how you know you're making the difference that you are aiming to make a difference.
Okay. I think, you know, the key thing about evaluation is actually understanding where you are to start with. Understanding where you are to start with, so it's very much about actually and using the stories and using the observation to understand where you are. A lot of them are simple changes, so they just do it because then you get the patient stories where actually last time I was here it was awful and this time things are a lot better. So using some of the methods of collecting data to use as part of the evaluation. And there has been some work done on the, University of Sheffield have done some work looking at using experience-based design as a process and done some evaluation on that. And I think, and in terms of the process, the most difficult thing is actually the resource identification up front, really, and the time that it's going to take. Because people have this perception that if I take time out doing that, then I'm not going to be delivering the service. But actually, you know, patient experience isn't an add-on. It's central to us being able to deliver quality care, as Jocelyn pointed out.
I think measurement is built into the action groups. So the evaluation partly uses the measures that the teams themselves have devised. And I think it is very important to insist on the collection of data and measuring improvements as they happen, as it is as part of any process improvement. We are part of a programme of work with Oxford University and King's, which is looking at a process called accelerated experienced co-design, which is trying to see if we can speed it up, as it sounds, and it's got a financial component to the evaluation, trying to cost the inputs to the process, which hasn't been done so far. So that's ongoing.
Thank you. Over here.
I've worked on the front line in emergency rooms in downtown Toronto with a lot of very poor people and sometimes wealthy people, but in particular the poor, you know, flooding in because they have many more health problems than other groups, and elderly people as well that have no place to go beyond, you know, there's difficulties with not enough home care and not enough services. So I guess my concern is, I mean, it sounds like you're being very inclusive within the hospital structure, but what about the predeterminants of health? If you don't have the money for transportation to get to the clinic, or you're not, you know, you can't afford the nutritious diet to prevent cancer, you know, and all, you know, or exercise, all the other sort of mainstream, you know, like how are you inclusive to these groups? And I'm just wondering about the structure of your healthcare system too. Do you have a two-tier system, or is it socialized medicine?
Now that's a whole different talk.
No, but I'm just interested in that. How do you include these other groups?
Well, we have a system in which everybody is entitled to care. So there is absolute entitlement of everybody. It is nevertheless true to say that not everybody does have access. So homeless people in particular would really struggle.
Or refugees and immigrants.
Yeah. So we have problems delivering equitable care, but the entitlement is absolutely taken for granted. I don't think experience-based design is the solution to all things. I think it's a particular method for improving contacts with services and the way that services operate. And one of the things we'll be talking about tomorrow at the workshop is about how to make sure that professionals are inclusive of the range of patients who that service is designed to meet. And there are strategies for doing that.
Okay, we have time for one more question, so I guess that's you, Rick.
Rick Edwards, St. Joseph's Health Centre in Toronto. I have a micro question that I think alludes to a larger one, of course. So I was prompted by the patient in the video who said, well, we were suggesting you could do this and suggesting you could do that, and gee, we found that so how did she get to that point? Because I can imagine patients recommending something and the pushback would be, oh, it's a resource issue. We don't have those resources to do that, or it's, would take more time for the nurses to do such and such, or yes, but, or, so I'm wondering. And so once you've gotten over that hurdle, then I can imagine the spread would just, but so how do you respond? How do you get staff ready to hear it rather than just say, oh, we can't do it? And then the larger question about, I guess, organizational readiness or something like that.
The whole concept is about working together. It's very much about that recognising that whatever everybody has to offer is of equal value. And I think the big part is we talked about having the core group and having the leadership and ensuring that you have that leadership and the resource commitment in there, and being clear and being honest about what your criteria are for prioritisation. So it might be actually, well, we can't, in terms of the prioritisation, there has to be little or no cost. They almost have to be cost neutral. So that then almost, if that's one of your prioritisations, then things that are unrealistic are not going to come out. And the other big thing is that in reality, we always imagine that patients are going to come up with wanting this gold-plated service. In reality, they just want respect and dignity. And that is, if they want to be treated with respect and dignity, they want to be treated as people, not as a number, not as something that goes through the system, but actually as real people who have real individual and unique needs. And I think that so long as that's recognised and valued, I think that makes, we haven't really had any major problems with that.
Jocelyn?
Well, I would just say, again, one of those, that young woman, she talked very eloquently about the small things, and when the small things are done wrong, you feel like nobody knows you and you feel unsafe. And it's a recurrent theme working with patients and actually working with staff about their experience, is that it's the small things that drive people crazy. An awful lot of those small things can be sorted out by the frontline team once they've heard. And I think there is really something quite extraordinarily potent about staff hearing from their own patients. As the woman said, that they had never done that before. And that's something that all the groups of staff that we work with say. We have never, ever sat down in a room with our patients before and just listened to their experiences and talked with them about ours, of our experience of delivering the service. And somehow that, providing you can get that far, which you can carefully, that releases the kind of energy that people say, yeah, we can solve this, or we can send it up the tree until it is resolved.